My name is Frank Arnett, Professor of Medicine at the University of Texas Medical School at Houston. It is also my privilege to serve as President of the Alpha Omega Alpha Honor Medical Society. As President of the Society, I am pleased to introduce this taped interview of a leader in American medicine. This series is made possible by a bequest of the late Drs. David and Beatrice Siegel, who were faculty members at the Columbia University College of Physicians and Surgeons. They were distinguished physicians in their own right. The purpose of these taped interviews is to record for the benefit of current and future generations the character and spirit of some of the most distinguished physicians and surgeons of our time. An interview format is used, and the interviewer is usually a former student or colleague who is also a recognized leader in their own discipline. Therefore, it is my great pleasure to present a leader in American medicine.
Well, Fred, we've been friends for over 40 years, almost 50 probably, over 50,
yes,
yeah. Starting medical school together, and it's a pleasure for me to be able to interview you for this series of great men in science, and you've certainly had an unbelievable impact on the specialty of obstetrics and gynecology. I'd like to start sort of back, not quite at the beginning, but early in your career, when you were a young man and prior to World War II had decided to become an engineer, then entered World War II, were a Marine fighter pilot, and came home all of a sudden destined to become a doctor. Was there some major change in your life during that period of service that made you make this switch in professions?
I don't know. When you stop and look at your life as you get older and more mature like we are,
yeah,
you think, well, did I really plan what I was supposed to do? And I think that when I came to Ohio State in 1940 and roomed under the stadium in the Buckeye Club, most of the people there were engineers, and I was an engineer. And I liked engineering, and I enjoyed that. But then I decided I was going to have to go in the service, so I chose an enlistment in the Naval Air Corps, and then upon receiving my wings, became into the Marine Corps, and eventually became a Marine fighter pilot. And once I did that, and I had a lot of experience, about 18 months overseas, doing things that probably you shouldn't do, but what I was trained to do, and I did it well. But I decided that when I came back, maybe I really had a subconscious desire to be a doctor. And the war really changed my attitude to where instead of destroying things, I would try to help things. And that's my impetus and to come back and really begin all over again. It took 2 additional years when I got back out of the service to get my pre-med requirements, and we both then started medical school in 1947. So that's sort of the reason.
We both started medical school somewhat older, somewhat wiser, back from the war,
yeah,
married.
We were the first class in medical school at Ohio State that had all veterans.
Do you think as you compare yourself and your classmates as medical students in those days who were older, most of them married, many of them had children, that there is a significant difference from the medical students that you see entering your classes today?
I do, because our entertainment was with your wife and maybe with some other wives, and it was usually a quiet type of entertainment, and we worked hard, we studied hard, we belonged to fraternities of medicine, and that was sort of our social life. So we were very serious about the acquisition of knowledge, and I think everybody worked very, very hard to try to be and prepare ourselves to be a good doctor. That doesn't mean people today don't do that, but there was a difference probably of at least 4 to 5 years between the current physicians and the physicians of our time.
Now, during that period of medical school, you did work hard, obviously, because you graduated near the top of the class and were the president of our class during your senior year. You decided to take a rotating internship and why did you choose a rotating internship, and why did you choose Ohio State, where you had done your medical training?
Well, I liked Ohio State. I felt comfortable there. People, I thought, liked me. And I thought a rotating internship was a wonderful experience. It sort of, I was pretty certain what I wanted to do, because I sort of backed into obstetrics and gynecology by way of the Marine Corps, actually. I was a weekend warrior and used to fly fighter planes on the weekend during medical school. And one day I went out to the Port Columbus, and the major said, "Well, Zuspan, you're out of here." And I said, you can't throw me out of the Marine Corps. I need this, and I like this. And he said, "Well, you're out of here because you're a medical student and we can't draft you." And the squadron then, on Monday after that Saturday, went to Korea, where 4 of my friends were killed. So in the meantime, I decided I needed a job, so I applied for a job at something called the Rapid Treatment Center. And in the Rapid Treatment Center, there were a lot of people that were treated for venereal diseases, and many women, and nobody knew anything about the women's diseases, and I didn't either, so I read. That, plus the influence of our mentor, Alan Barnes, who was the chairman at Ohio State, who sort of mesmerized both you and I to go into OBGYN. So we did that, but before you did that, you had to do a rotating internship, which sort of reinforced the fact when we rotated through obstetrics that we liked it very much. And we then applied and became residents together, and spent 2 additional years at Ohio State, and then transferred to Western Reserve for our last 2 years there. So it was a good experience to be a rotating intern. It gave you time to sort of think and decide what you really wanted to do for the rest of your life.
Okay, as you mentioned, we did spend 2 years here at Ohio State in our residency, and then with the move of our mentors, Dr. Barnes and Dr. Hendricks, to Cleveland, we decided to move to Cleveland. Spent the last 2 years there. What do you think, as we went through that 4-year period, were the outstanding things that happened, changes that occurred, learning that went on, that prepared you for your career that you've enjoyed?
Well, I've thought about that many times, and I know that we both have been involved with large residency programs. And you and I were involved with a small residency program. There were 3 residents per year. We basically had day-to-day contact with our mentors. We had an open-door policy to always be able to go in and talk to them when we had a problem. And I thought this smallness and the interest that people had in us is probably what shaped our lives more than any single thing. And at that time, as residents, we were taught that the acquisition of knowledge was important, and that this was when our research efforts began as a first-year resident, and continued at that time. If we had something that was of benefit for our research, our mentors got us on national programs, and they sort of put us in the mainstream of academic medicine at that time, and I began to like it very much. So did you. We just sort of flowed along. I remember when we were senior residents, both you and I were going to go into practice together in a small town here in Ohio. And somehow we sort of apologized to each other and said, well, it wasn't quite what we wanted. And you stayed in academic medicine in Cleveland, and I went for a short stint into the mountains of Kentucky to sort of work like a medical missionary. I actually worked for a United Mine Workers Hospital there for 2.5 years, which was, in retrospect, a very wonderful part of my life, because I had to grow up very quick. I had to be on my own completely, and I had no mentors except to think about what people told me I should have done, and I tried to do. So it was a very rapid growth period. And then I returned to Western Reserve to become a fellow. And as you recall, you and I shared small laboratory space. Since I did catechol and was starting to do catechol, you gave me the bathroom, because And you had the rest.
That was the only dark room.
It was the only dark room. So those were nice days, and we worked hard as residents and as fellows and enjoyed what we did. We never worried about anything other than being productive and trying to acquire knowledge the best way that we could.
Maybe we could go back to the beginning of the research, because one of the things that you hear frequently today is that residents have to do a research project in order to complete their training. Many of the programs require this. But the residents complain that they don't have time. Usually they are not basic type projects such as the one you were doing, where you actually had to, as I recall, look through a microscope and count oocytes on fetal ovaries. Do you think that our residency program was that much easier, that we had a lot of spare time, or how were you able to work this research in, and do you think it was the right thing to do, or that you should have done just some small clinical project and then done your more basic research later?
I thought it was the right thing to do at the time. The time that we devoted to it was not during the working day. It was at night. And it was not unusual to, get up in the middle of the night and go work on rats or something such as that. I think one of the things that our mentors provided us with, if we wanted supplies, they bought us supplies. If we wanted space in the laboratory, they gave us space in the laboratory. It was sort of up to us to say what we wanted, and once we said it, it was then provided for us. And then it was up to us to either succeed or to fail in what we did. So that I think that the milieu that we worked in was provided, and sometimes we were lucky and the project went well, as research does, and sometimes it didn't. But at least we felt good about it. But we did it on our own time after hours.
You think another factor might have been that our mentors were frequently there when we were there at midnight, too?
Yes, they were always around. You could push a button and one would always appear. So I think that the relationship of our mentors was exquisitely important in our productive life. And it was that interpersonal relationship that we had. And we had our problems, and we'd always go to them, and they would never answer the question, but they would bring up other questions and make us think about, well, go do it. And they sort of let us do what we wanted to do. I'm sure if we did things bad, our hands would have been slapped or something. They would have said something, but they basically treated us like very mature people, and we responded accordingly.
You spoke a little bit about the residency training. During that residency training, as I recall, and I'm sure you do too, we were pretty much on our own with supervision. The supervision certainly wasn't of the close type of supervision that residents today are either forced to have or enjoy having. Do you think that the type of laissez-faire training that was going on in those days with remote supervision or supervision when you got in trouble was equivalent in terms of training or in terms of safety to the patient, to the type of supervision that is much more hands-on that residents are getting today?
Well, I've had a lot of soul-searching about this, and I have gone back and said, did I really hurt anybody in doing things like this where I didn't have a lot of supervision? And I came up with the answer, no. And the one thing that it nurtured maturity very quickly. And I am impressed occasionally when people finish now, they don't seem to have the self-confidence that you and I had when we finished our residency program. And perhaps it's because the system that we now have has forced faculty members to be physically present and to really almost take over the case at times, which I think negates growing up or having maturity. So that there are good things about the system today and there are bad things. And I don't know which is correct, except that I think that we did okay. And we survived, and the patients survived, and everybody seemed to be happy.
All right. There's another factor that I think is important. That's really a major change, and that is we had the clinics that the residents fundamentally ran, and this was the indigent patient by and large. And then there were the private practices of all the private physicians as well as our full-time faculty members. Today, those clinics are rather disappearing, and the majority of the patients are private. And the residents, while they still take care of the patients, it's a different relationship. Again, do you think that the patients who were cared for in the clinics got a good, bad, or indifferent brand of health care as compared to those patients who were being cared for in the private sector?
Well, I think studies have shown that the people in the clinic setting got equally good care, if not better care, oftentimes than people in the private setting. There was a lot of compassion that each of the residents had toward their patients. And as you'll recall, many of us had our own sort of personal patients when we were senior residents. So that I thought we delivered a very fine quality of health care to the clinic population. It was enjoyable. The patients liked it. We liked it. Most of them, of course, at that time did not have a choice to seek private health care as they do now. And even today, many people would prefer to go to a clinic environment where you have a lot of supporting structures around you. You have social service people, you have nutritionists, you have genetic counselors, you have a lot of people that are available for the impact that the patient presents. So that it's a matter of stretching expertise, and this is what a clinic environment usually has.
You mentioned your sojourn in Kentucky with the United Mine Workers and how you felt that was an important part of your life. What would you say, if you just had to say one thing that most influenced your subsequent life that you learned during that experience? What would that be?
You mean in Kentucky?
In Kentucky.
I think what I learned was that the people there were very poor. They were very proud. They had diseases that were sort of indigenous to an inbred population. They learned to accept a tragedy. They learned to accept adversity and problems such as this. For example, I operated on literally hundreds of patients who had double incontinence. They had incontinence from their erectile sphincter that was torn during delivery, and they also had incontinence from their bladder because of birth trauma. They learned to put up with this, and I remember the first person I operated on assumed that she would die when she came in the hospital, because that's the way most people did. And so she almost like sacrificed herself so I could operate on her. And she was so surprised that she went home. She was continent of bowel. She was continent of her bladder. And pretty soon, the women were lined up all the way down the road, waiting for me to operate on them because she didn't die and she was cured. So they didn't expect a better way of life. And I appreciated the tenacity that they have. They were wonderful people to take care of.
You then came back to Western Reserve as the Ogilvie Fellow.
I did.
And started on your academic career, which progressed very rapidly. But at Western Reserve during those early years, you developed your interest, or honed your interest, I think, in pregnancy hypertension. What got you started in pregnancy hypertension? This has been a seminal part of your career throughout your entire life, your interest in hypertension in pregnancy.
Well, that's hard to answer. My first paper was fetal gonadal activity in toxemia of pregnancy. That's when I was a first-year resident. I wrote that paper. Probably one of the better papers that I ever did, incidentally. I did it all by myself. I was proud of that paper, and it got published in the American Journal of OBGYN, which both you and I now edit. And then some other papers that I did related to toxemia, but I never really became interested in hypertensive diseases as a cardinal example until I went to the Medical College of Georgia. My research interests were in catecholamines, and when we were fellows, I remember we applied and got my first NIH grant, and they were very helpful in getting me started on this particular career. So catecholamines, the stress hormones related to hypertension, and that's sort of how they fused. In other words, I was interested in the laboratory and the basic studies of catecholamines, and then later on in the clinical arena with hypertensive disease of pregnancy. It was sort of a fusion of the two interests into one denominator.
You mentioned almost casually that you got an NIH grant. And you and I both remember in those days that if you could ask a decent question and write a very small grant and spell your name correctly, that you almost always received your first RO1 award. We know today that people have to work years and years and years and may never receive an RO1 award. Do you think that has discouraged young people from entering research in our specialty? The fact that it is so difficult to receive funding for their studies? And do you have any suggestions as to what might be done to help that situation, if there is?
I think without question, there's no question in my mind but what the milieu that we functioned in, when we wanted laboratory space, Alan Barnes and Chuck Hendricks provided it for us. When we wanted supplies, they did. And this was sort of an in-house grant that they had. And then as we sort of grew up and finished our residency, we then applied to the NIH, who then gave us money to continue what we wanted to do. I would think that if today I was faced with an obstacle that I could not have money to do investigation, that I probably would not have stayed in academic medicine. So I think it's very significant for young people to have an opportunity to carry on research. Instead of being the seasoned investigator that you have to be now to be able to compete for RO1 monies, that is not the answer to the problem. The answer is, if you wish to try to get people interested to be trained in scholarship, whatever it might be, whether it's molecular biology or whether it's clinical science, that research support is critical the first 2 or 3 years that they're in academic medicine. Without that, I think that they're going to become basically what many people are now. They're practitioners disguised as academic medicine.
Well, do you think it's necessary with the explosion of knowledge, the explosion of techniques, technology, that someone who is truly interested in research, say get a PhD during the medical career, or go and work with a mentor who is well equipped in a laboratory in order to get proper training? It seems to me it's very difficult to go back into the closet that you and I were in and work by ourselves and accomplish the types of things that are expected to be accomplished today.
Yes, your point is well taken. I'm not so sure you have to get a PhD. I think it would be wonderful if you wish to stay in academic medicine to have a PhD. It might help you get a grant. It won't help you get a grant unless the grant idea is correct. But I think that the sophistication that is now present, that is necessary if you're really going to do investigative work and apply for grants, that you have to spend a minimum of 2 additional years beyond your fellowship training in order to understand what science is about and to have the appropriateness to be able to be competitive. If you don't do that, then I don't think that you probably are going to be capable of getting funding.
All right, you started your career in investigation, and we were all doing a private practice, as we had to do then to support ourselves.
But our private practice was only a half a day a week.
That's right.
That was it. That's all we were permitted.
A very small amount. And very soon after your return, I think it was 3 years, you were offered the chair of OBGYN at the Medical College of Georgia, and took that chair. And I'd like to know, and I think the audience would like to know, how you felt as a very young individual walking in to the chairmanship of a very well-established, very good department of OBGYN.
Well, I know how I felt. I felt scared. I said, why have I done this, you know? Because I think I was 36 or 37 years old. And I said, this is really a bit much, you know. But, you know, you do what you have to do. And I was fortunate enough to be able to recruit some very excellent people. And there we enjoyed the privilege of writing NIH grants and getting NIH grants and doing things that were appropriate. That's when I really first became interested truly in hypertensive diseases of pregnancy, because it was everywhere. Everywhere in Georgia, women had hypertension in pregnancy. So I sat back and they taught me a little bit about how to do this and the clinical things that they understood and did so very well before I ever got there. And I tried to then meld it with the clinical investigation that we did, and we did a lot of very nice things in looking at hypertensive diseases of pregnancy. And I was there for 6 years and did that in great depth. So that was one of the important parts of my life, was learning about hypertension in pregnancy. And I give credit to the people in Georgia for teaching me that and letting me participate in healthcare there.
When you walked into that department, did you have a plan, what you were going to do for the next 5 or 6 years?
Well, I had a plan, but I didn't know whether anybody else would think it was a good plan. I tried to have a plan, and I said I wanted to build a core of clinical investigation, and I was able to get some laboratories, and I recruited an MD, PhD to help run the laboratories, and we had a lot of fun. It was spent a lot of time doing investigation in hypertensive diseases of pregnancy. So I'd say yes, I had a plan. I had a plan to continue the excellence of clinical teaching and to add to it the depth of good, sound, basic science investigation.
Well, there are a lot of wonderful things that came out of that department and that experience at that time. Two I'd like to have you comment on. One was the use of magnesium sulfate intravenously, which is certainly nationwide now, and with some recent studies probably will become worldwide finally.
Right.
And the second is the very interesting work that you were doing in new methods of teaching medical students with Virginia Zackert and Lee Wiles.
Oh, that was exciting, yes. Well, anyway, people give me credit for discovering intravenous magnesium sulfate. And Richard Turpin who was the previous chairman, had used intravenous magnesium sulfate for years. And I just picked up on what they had used and refined it into a fairly specific way to give it, which caught on and is now sort of the standard of care, I think, probably for the world in treating preeclampsia. So I don't take credit for it. I take the credit for being organized for it, because they say, they think you discovered intravenous magnesium sulfate. I said, no, and neither did you people. It happened back in the early 1900s that it was available. So that, but the exciting thing was that I said, you know, I was president of an Association of Professors of Gynecology and Obstetrics at about that time, and that was an organization that we both helped found, and it had to do with everything except clinical medicine. It's how to teach and how to run a department and things of that sort. And I thought we ought to look at how people acquire knowledge. And so Lee Wilds, I interested him in this, and we got a large grant from the Office of Education, of all places. And we then hired Virginia Zachert, who was an industrial psychologist, to look at ways to educate students. Should you educate students by program learning or by the usual didactic method of lecturing? So we chose our best lecturer, who could actually, if he wanted to, he could write with both hands at almost the same time on a blackboard. He was a marvelous speaker. And we said, we're going to have you teach the best that you can possibly teach. And we divided the class into segments to where, and then with the other segments, never heard a lecture. They only had program learning, small seminars and things of that sort. Turned out at the end of the time, the program learning was better than the gifted lecture that we had. And that made us scratch our head a little bit. So we pursued that further. And we had many of our students writing the program text because they said, you don't know how to do it correctly. You go from A to Z, and we need to go A, B, C, D. So we had many of our students writing the program text, and they were tested and retested. And it was an exciting era of learning. We did that for 4 years of dividing the classes up appropriately to show that either way is a satisfactory method. And then here at Ohio State, program learning began after that as a form of education. So it doesn't matter how you impart knowledge. Is the person receptive that is going to do it. The program learner has to have more individual security to do it themselves. They have to say, I'm going to do this. In other words, the lecture is the least effective way, because you can sit there and dream and go to sleep when somebody's talking, which they may be doing now, you know, or something like that. So that was it. It was an important contribution, I think, to medical education.
And one that still goes on.
Still goes on, yes.
Well, then you left Georgia for the University of Chicago.
I did.
And took on a bigger department in a bigger city.
And in a maternity hospital.
In a maternity hospital. What were your reasons for accepting the position at the University of Chicago?
Well, I guess I'd have to say I don't know. But they worked on me, and finally I decided, well, we would try that. And fortunately, my family, my dear wife Jane, went along with it, along with the kids, and we moved to Chicago. And it was a wonderful 10 years, because it was a totally different venue than at the Medical College of Georgia. It was more of a research venue. We had a lot of research space. We still did clinical medicine, but clinical medicine was less important. People there ask you, what are you doing in your research? And instead of saying, how many patients did you deliver and what operations were you doing? So the focus of attention was an investigation and the acquisition of knowledge. And for 10 years, I enjoyed that very much.
From a research standpoint, you continued to work on hypertension in pregnancy.
And catecholamines.
Right. You also did some very fine work in drug problems in pregnancy.
Right. We backed into that. We realized that we had a large number of pregnant drug addicts who were coming to Chicago lying in hospital. None of us knew anything about drug addiction. So I decided, this is the perfect place. Here is a woman who's trying to poison herself and her baby. Why shouldn't we be observers for this? So I wrote a grant to the federal government, and they were kind enough to give me a lot of money to look at drug addiction in pregnancy, which we did. And we interfaced this with the Illinois drug abuse program and had a marvelous experience of understanding about drug addiction in pregnancy. And actually then went on to develop what is now still the standard of care for detoxification using methadone, to where if you get down to a certain level, the baby is less addicted. So we did some good things in that. But it was strictly a clinical investigation process. It had very little basic science involved, except for the catechol that we did on the babies and also on the mothers to show that there is a change in their sympathetic nervous system during drug addiction.
Are there particular principles that were developed in catechol metabolism in hypertension in pregnancy that came out of that experience in Chicago that you think are important?
Basically what it said was that you have a flush of catechols when you are in active labor after 4 centimeters of pregnancy, or after 4 centimeters of dilatation. And as pregnancy progresses, you produce more catechols, which means that if you happen to have a transient form of hypertension, your hypertension often gets worse as active labor goes on. And I think this is something that people did not know before. We also looked at long-term investigation of the production of catechols in pregnant women, which had never been done before. We did that actually in Georgia and then carried on to do some additional work in Chicago. So yes, I think that the catechols fused well with that. The only problem I had with catechols was that there was really nobody for many, many years doing any catecholamine research in an OBGYN. And I felt very lonesome because I was supposedly the expert in this area. And I would go to catechol world meetings and things of that sort, but it would have been nice if there had been other people that I could have interfaced with in our specialty. There were into the 80s, but in the 50s, 60s, and 70s, there really was nobody except my own laboratory that were doing them. And when I moved to the University of Chicago, somebody in pediatrics was doing catechols, but beyond that, we were the only 2 laboratories in the city of Chicago doing catechols at that time. They were difficult to measure, but they're easy to measure now with different types of sophisticated equipment. So back in the early days, they were hard to do.
One other project that I recall that got great prominence in Chicago was a follow-up on Arthur Herp's observation in Boston that the daughters of mothers who'd taken stilbestrol during their pregnancy had difficulties. As I understand it, you had a large population there and did some very nice studies on those patients.
Well, Bill Diekman, back in, I think it was 1950 or 51, published a randomized prospective study on the use of stilbestrol in pregnancy. And the people in the East Coast, namely at Harvard, were big on using stilbestrol, and he felt that this probably was inappropriate. So he decided to do a randomized prospective study in pregnancy loss, prevention of preterm labor, etc., on the population group in Chicago. Published a paper, was sort of forgotten when the DES question came up. I then finally found the original cards that identified whether it was odd or even. Well, that sounded easy, except it was never said whether it was odd or even. So we found some of the old medication, and I gave some of the old medication to Dr. Kim, who was our head of endocrinology at that time, and asked him to analyze it and tell me which was estrogen and which was a placebo, which he did. And I gave him all kind of numbered tablets so that he would not know. And we then broke the code. We were then fortunate enough to get a large American Cancer grant to try to follow these patients up. And we had a big study which included a urologist, epidemiologist, several OBGYN people looking at the patients themselves. And this study then concluded that there was a slight increased chance of some reproductive problems in both male as well as female. And at that point in time, it was continued in Chicago, and unfortunately resulted in a lawsuit to the Eli Lilly Company and to the University of Chicago because of so-called non-informed consent for these patients. Whether or not that was true, I don't know, because everybody was dead who did the study. But it was a lawsuit that was settled out of court. And so maybe I should never have found the odd and even
the data.
Yes.
After building a very distinguished department in Chicago, you decided one day to move to Ohio State, which was where you started.
Yeah, that's like a good obstetrician goes back to the womb.
That's right.
So that's what I did.
Ohio State at that time certainly didn't have a department that would have been considered one of the most distinguished departments in the country. It was small, and I wonder why you decided to leave this very prestigious department that you'd led for 10 years in Chicago and come back to Ohio State.
Well, it was a joint decision between my wife and I.
As most decisions are.
Yeah, usually it's the wife that makes a decision, you know. Anyway, we decided that after 10 years, and you and I used to talk about how long you should be chairman, and I think we pretty well agreed between 8 and 10 years, you probably are not very effective after a period of 10 years. I'm not sure that's true now. 12 might be the maximum now. But certainly after 12 years, you really aren't very effective. And both you and I have given up our chairmanships before that period of time. So I gave them the best 10 years of my life, and my wife and I decided that we would rather live in Columbus. So we moved to Columbus. And it's been a marvelous experience for me to be able to come back and sort of rebuild a department, rebuild the third department in my life, which we finally struggled and got it built into, I think, one of the top 10 departments in the United States, with the help of many people. And so it's interesting. Each department that I've been at is different. There are certain pluses and minuses everywhere. There is no such thing as the perfect department. But in the department here, we've been able to build some basic science studies, good clinical work, and things of that sort. So, and probably to continue to emphasize that teaching is the most important single item when you're trying to train medical students, residents, and fellows, and to try to provide them with the proper milieu in order to function.
Well, you've been through 3 departments now over 3 decades, roughly, a little more than 3 decades, and undoubtedly have seen some significant changes in our specialty. Would you like to list maybe the 4 or 5 most significant changes that you've seen in our specialty, with a little discussion of whether you think they've been good or bad?
Okay. There have been a lot of changes. I'm not so certain that the changes have been complementary in what has happened. It's been the changes of time more than anything else. We have been privileged to be present in, I think, the most exciting specialty of what I call the 90s and the 2000s. When other departments have had trouble recruiting students for resident positions, we have been very gifted in being able to, always for the last 10 or 12 years, we've had more U.S. graduates who wish to be present in OBGYN than there were before. And I know when one of these previous tapes was made by Howard Taylor, who was then chairman at Columbia University, and our mentor, Alan Barnes, they talked about the problem of recruitment. Well, we have been so fortunate. We have not had the problem of recruitment. So one single thing I would say is that we have been indeed fortunate to be able to have recruitment that has changed. When you and I were in medical school, we had 2 women in our class. At the present time, 40 to 45% of women are in medical school classes. 55% of women are in OBGYN. And that's been pretty stable now for a number of years. So there's been a major change as far as sex ratio is concerned. There's been a major change as far as the quality of the residents that we've been able to recruit. The residents are so smart now that they almost intimidate the professors because they come with very high IQs. They are all AOA, most of them are AOA members, Phi Beta Kappa. They've won every honor that there is. And we have such a wonderful choice of these people that it's been so privileged to be able to take residents and to really put them into an environment for learning.
Why has that occurred?
I think it's because of a lot of things. I think the women's liberation movement would be one item. That women are standing up now more for their rights and what they want to do, and I think that's wonderful. I think that the right for the woman to choose as far as a pregnancy is concerned is correct. And this, of course, is a big issue, whether or not abortion is right or wrong. At least the woman should have the right to choose. And I know both you and I have felt very strongly about that. Additionally, I think that the consumer, the woman, has been able to have a voice in healthcare, more so now than ever before, to where, when you and I were residents, we were present at something that we thought always took place, which was natural childbirth, which was the fact that the husband was present in the delivery room. And then I went to Chicago, and it was illegal. But, that was like 15 years later. So that the health care thing has changed tremendously. So there are a lot of good reasons why. Plus the fact that if you look at our specialty is an interface between surgery and between medicine and between prevention and between healing. So we have a spectrum that nobody else has. And the spectrum that nobody else has is because that we look specifically at the diseases of female and how to prevent things. How do you prevent aging? How do you prevent problems with trauma and child care? How do you prevent pregnancies? And a lot of the explosion of knowledge has come because of the fiber optic system, being able to use it with the laparoscope. And we do surgeries now that we never did before. So we have a technical specialty. We have a broad spectrum specialty. We have a specialty that basically begins at birth and ends at death. So that I think this has been very appealing to many, many people to be able to be at the forefront of what I call women's health care. So this is why we have people knocking at the door. And there are many people that can't become obstetricians and gynecologists, and they're devastated over this.
Do you think the development of the subspecialties, with which you and I had a little bit of a role, has made a beneficial effect or deleterious?
Oh, I think it has made OBGYN a different specialty in the eyes of students and of residents. And you and I were both involved in the origination of the specialty of maternal fetal medicine through the American Board. But at the same time, oncology was developing and reproductive endocrinology and infertility were developing. This then set us aside, I think, as an academic pursuit, that here are people who have a very special knowledge in a very special area and know more than anybody in the world about this. So I think that our subspecialty areas was very significant in turning around what we've been talking about, the interest of the student, the interest of people in pursuing this particular area. Yes, I think it was important. And I know in my presidential address to the American Gynecologic and Obstetrics Society, I pointed this out, along with the fact that more and more women were coming into our specialty. These are all positive things.
I'd like to turn to another area that I know that you've enjoyed for the last 20-plus years, and that's being an editor of the American Journal of Obstetrics and Gynecology. We've both had the opportunity to do that.
For 27 years.
27 years. Long time. Time flies. Would you characterize that activity as being significant in your life and as being an activity which you think has made a difference in the specialty?
I'd have to answer yes, yes. If you ask me, is this a good expenditure of my time, I'm not so sure I can be as positive as that. I probably could have done other things if I had not been an editor. But I find that being an editor, selfishly, has made me read papers to keep abreast of knowledge all of these years, and that the privilege that we've had in trying to set up peer review in a very systematic way that both you and I did in the American Journal of Obstetrics and Gynecology has made the American Journal of OBGYN in the top 2% of 4,600 journals in the citation index. So that we must have done something correctly during this period of time that has made this particular journal one of great eminence in our specialty. And I guess a lot of people, at least in academic medicine, consider this the accolade of their life, because when we're introduced at meetings, they never say you're a chairman, they say you're an editor. And so I've often wondered whether that's good or bad, but anyway, it's been a privilege that we have both enjoyed and I think have made good contributions to the acquisition of knowledge and science.
You've also been president of almost everything. If you had to just, in a very short space of time, pick out a presidency that you felt had the most impact on the specialty of obstetrics and gynecology, which one would you choose?
I'd probably pick the International Society for the Study of Hypertension and Pregnancy, which embraces mostly OBGYN people, but also people in other specialties. Marshall Lindheimer and I began a small study group when I was at the University of Chicago. 20 people we invited. And this organization has now grown to 65 countries. I have friends all over the world. It's been a very exciting arena to function in, to realize that we've been able to hold hands with everybody in the world about hypertension and pregnancy. I think I'd put that as number one as far as the contributions to the good of world medicine.
All right. We have a relatively short time left. And as I was once told on a radio program, we've got 30 seconds left. Will you tell me all about RH disease? I'm going to make it easier for you. We have a few minutes left, and I want you to put your crystal ball in front of you and start telling me and our audience some of the things that you think are going to be happening to our specialty in the future. For instance, do you think that the ability to become an academician, which for us was pretty easy, I mean, it was a simple decision, is going to be as easy or rewarding in the next 10 or 15 years as it was when we started in 46?
Okay. That's sort of a free-floating question. I love it. I'll try. Okay. Anyway, if people say, would you go into medicine again if you had it to do all over again? I'd say, I sure would. I have had so much fun in medicine. It's been so good for me. I've been good for it. It's been a very positive part of my life. So I would say, yes, I would go to medical school again. Yes, I would become an OBGYN person. Yes, I would be interested in high-risk obstetrics. Would I have the same entree in becoming an academician? I think I'd have more trouble. I think I'd have to prepare myself better. I'd have to, after my fellowship, I'd have to take 2 or 3 years studying so I'd be able to be competitive. But yes, I would do that because I would think that would be important for my projected lifestyle. I'm very concerned now, I believe, about what's happening to medicine, academic medicine. People are not searching for science, for answers to questions like I think that they probably should. People are now searching for money because it's very difficult to run medical schools. They're very expensive. And that the goal is perhaps a little bit different than when you and I were young. Our goal was to do investigative work, to publish papers, to present papers at national meetings and things of that sort. I'm not so sure that these are the goals now. So I think it would be a little more frustrating to try to do this. But as far as the total outlook is concerned, it depends upon what you get used to. Managed health care people don't like, patients don't like. Does that mean it's bad? No, not necessarily. Does that mean it's good? No, not necessarily. Is there a better way? Probably. But it all gets down to whether or not people can afford to do the things that they want to do. I think that people are probably a little less oriented toward others and more oriented toward themselves than they used to be in the past. I think we were taught that the privilege is to give. And if you cast things onto the water, it will come back manyfold. And I think both you and I believe that very much. So that there are trying times. That doesn't mean that we can't do things. That doesn't mean that we can't be productive. That doesn't mean we can't have good teachers, because the basic quality is still there. Good teaching is still the foundation. But for academic medicine, I think good research is an essential part.
Let me just finish on teaching, because I agree with you. I think it's an extremely important part, and good teaching is still there. But with the care lines and all the other techniques that are being developed to manage patients in a more efficient way, we're coming into an era of what I would call algorithm medicine. Where somebody develops an algorithm that hopefully is research and evidence-based, and you're given the algorithm, and you follow that algorithm. You won't get sued if you follow the algorithm. The patient will hopefully get well. Do you think this is a good technique for learning? You've had a lot of time studying learning, and do you think it's a good technique for patient care?
Well, I would think that it probably gets people down to a common denominator. I'm not so sure it's bad for patient care if the algorithm is appropriate for current therapy as well as future therapy. It does take away the individual thought that people have, and maybe physicians who have always been individualists may not like that so much. They may fight a little bit about it. But they will do it because they know that if they don't do it, they may be in difficulty, and the difficulty comes from the legal profession, which has dramatically changed, I think, how people think, how people do, so that the lawyers often dictate what you have to do, which is the algorithm. It's not all bad, but it's not all good either.
Well, time is up. I've certainly enjoyed this interview. I've enjoyed our over 40 years of wonderful, close collaboration and intense friendship. It's meant a great deal to me. And I think we've practiced medicine in an absolutely wonderful time.
We have, and I sort of wish that our time capsule would go on forever, but it won't. And I, again, have been privileged to have you interview me, and I would want nobody else other than you to do this. So I thank you very much, and we will conclude at that particular point.